Okay, so let's dive in. We've got this material you shared, all focusing on respiratory acidosis.
Right.
Our goal here is really to, sift through it, pull out the key takeaways from these sources for you, the listener.
hmm
Figure out what it is, what causes it, how it looks different, acutely versus chronically, how it's diagnosed, and importantly, how it's managed according to this info.
Let's jump right in then. So the sources give us a pretty specific definition right off the bat.
Okay.
Respiratory acidosis. It's a clinical disorder, and they define it by the numbers. pH less than 7.35 and PaSHU2 greater than 45 millimeter Hg.
Less than 7.35 pH, PaSHU2 over 45.
Got it. And they also call it carbonic acid excess, which, that name itself kind of points you straight to the underlying issue.
Carbonic acid excess.
Yeah.
Yeah, that definitely signals an acid buildup. And CO2 is the key player there. So what do the sources say is driving this? Why does that CO2 pile up?
Well, the core mechanism described is pretty straightforward. It's inadequate excretion of CO2.
So the lungs just aren't doing their job effectively enough.
Exactly. Ventilation isn't sufficient. Think of it like a room with poor ventilation, right? CO2 builds up. Same idea in the body.
Okay.
Poor ventilation means CO2 hangs around in the bloodstream, raising those plasma concentrations. And that CO2, well, it combines with water, forms carbonic acid.
More CO2, more acid. Makes sense.
Right. Pushes the pH down. And the sources also note, importantly, that inadequate ventilation usually means PO2 goes down too. Less oxygen getting in while CO2 builds up.
Got it. So double trouble, really. Now, the material makes a clear split between acute, the sudden onset, and chronic respiratory acidosis. What kind of causes are listed for each? They sound quite different.
There really are different scenarios. For acute, we're often looking at emergencies. The sources list things like acute pulmonary edema, maybe aspirating a foreign object.
Like choking on something.
Yeah, exactly. Or lung collapse, atelectasis, pneumothorax, even an overdose of sedatives that just slows breathing right down.
Okay, serious sudden events.
But it's not only emergencies. It could also be, say, severe sleep apnea, really bad pneumonia, ARDS, acute respiratory distress syndrome, or a sudden downturn in someone with severe COPD.
Right. Things directly hitting the lungs or breathing control. But the material also talked about the mechanics, didn't it? The muscles involved.
Absolutely. If the muscles responsible for breathing aren't working properly, you just can't move enough air. Simple as that. So the sources mention conditions that impair respiratory muscle function, leading to hypoventilation. Things like severe scoliosis messing with the chest wall.
I see.
Or neuromuscular diseases. Muscular dystrophy, MS, myasthenia gravis, Guillain-Barré syndrome. These all interfere with the signals or the strength needed for breathing.
Okay, so problems with the breathing pump itself. That makes sense for acute situations. What about the chronic causes, the ones that develop more slowly?
Chronic respiratory acidosis, according to the sources, is mostly tied to long-term pulmonary issues. Think COPD, that's emphysema, and chronic bronchitis.
The big ones.
Right. Also, obstructive sleep apnea, if it's persistent. And interestingly, severe obesity is listed too. In these situations, the ventilation problem creeps up gradually.
Leaving the body some time to try and adjust, maybe.
Exactly. And that leads into how the body reacts. The sources stress that the clinical signs, what you actually see, really depend on whether it's acute or chronic.
So what does that sudden acute version look like?
Well, with acute, the CO2, the hypercapnia happens fast, so the effects can be pretty dramatic. The sources mention things like increased pulse, higher blood pressure, faster breathing rate. The body's trying hard to compensate.
Kind of an alarm reaction.
Yeah. And neurologically, you might see confusion, disorientation, maybe a decreased level of consciousness. And here's something really striking from the material.
What's that?
When the PaGO2 climbs above 60 millimeter Hg, it actually triggers a reflex. The blood vessels in the brain widen, increasing blood flow there.
Oh, wow. Increased blood flow to the brain just from high CO2.
And in very specific cases, like under anesthesia, the first sign could even be ventricular fibrillation, a dangerous heart rhythm.
Ventricular fibrillation. That's really serious and not something you'd immediately link to breathing, maybe. That's a key detail. What if the acidosis gets really severe?
Right. If it's severe, that increased cerebral blood flow we just talked about can lead to increased intracranial pressure, ICP.
Pressure inside the skull.
Yeah. And you might see signs of that like papilledema, swelling of the optic nerve, or visibly dilated blood vessels in the eyes. And crucially, the sources link severe acidosis to hyperkalemia.
High potassium. How does that work?
It's a direct consequence of the acidity. The blood is flooded with hydrogen ions, H+ they are. To buffer this, these H+ ions move into the body's cells.
Okay.
But to keep the electrical balance across the cell membrane, potassium ions, K+IOR, get pushed out of the cells into the bloodstream. So H+ in, K+ out.
A direct trade-off.
Yeah.
So the acidosis itself actively raises blood potassium levels.
Precisely. It shows how these imbalances ripple through the body's chemistry. So that's the acute picture. How does chronic look different?
Yeah, you mentioned the body adapts over time.
It does. So in chronic cases, because the CO2 increase is slow, the body has time to compensate primarily through the kidneys. If the PaSO2 level doesn't completely overwhelm this compensation, then the person might actually be asymptomatic or have very few symptoms, even with high CO2. The sources make that point.
So they might not even realize how high their CO2 is.
Potentially, yes. However, if someone with chronic respiratory acidosis has a sudden jump in their CO2 level,
Like getting an infection on top of their COPD.
exactly, then they can develop those acute-like symptoms. The cerebral vasodilation, increased ICP, maybe cyanosis, fast breathing. But here's the fascinating part about the slowly progressive cases, like long-term COPD.
What happens there?
Their CO2 levels might climb over months, years, and their kidneys adapt by holding on to bicarbonate, which is a base, to buffer the acid.
So the kidneys are fighting back against the acidosis.
Right. It's called renal compensation. Because of this, these patients might have very high PaCO2 levels but not show the typical confusion or other signs of hypercapnia you'd see in an acute setting because their pH is somewhat stabilized by that extra bicarbonate.
That adaptation is pretty incredible.
Yeah.
But it leads right into something the sources flag as really critical, a quality and safety nursing alert. This is about the hypoxic drive, right?
It is, and this is absolutely essential to understand. The sources explain that in people with long-term COPD and chronically high PaCO2, they mention typically over 50 millimeter Hg,
Right.
the respiratory center in their brain, which normally responds strongly to CO2 levels to stimulate breathing, becomes less sensitive to it. It sort of gets used to the high CO2.
So the main signal to breathe high CO2 isn't working as effectively for them anymore.
Exactly. It's blunted. So for these individuals, what becomes the major stimulus to breathe is actually low blood oxygen, hypoxemia.
So they're breathing because their oxygen is low, not because their CO2 is high.
That's the hypoxic drive. Now, here's the danger the sources clearly warn about. If you give these patients too much supplemental oxygen, say high concentrations,
You raise their blood oxygen levels.
and you take away their primary stimulus to breathe.
Oh. So giving them lots of oxygen could actually make them stop breathing properly.
Potentially, yes. It could lead to respiratory failure. So the material is very clear. Oxygen needs to be administered cautiously, usually in low concentrations if needed, specifically to avoid knocking out that hypoxic drive. It's a delicate balancing act.
That's such a crucial point. It feels counterintuitive to limit oxygen, but understanding that mechanism changes everything. Okay, so moving on. How do you actually nail down the diagnosis? What are the key tests?
Well, the gold standard, according to the sources, is arterial blood gas analysis. ABGs.
That gives you the hard numbers.
Exactly, the pH and the PaSO2. And the results that confirm it are just like the definition we started with. pH less than 7.35, PaSO2 greater than 45 millimeter Hg.
And what about bicarbonate? Does that tell you anything?
It does. The sources say in acute acidosis, bicarbonate might be normal or just slightly up, but in compensated chronic acidosis, where the kidneys have been retaining bicarbonate over time.
The body's adaptation we talked about.
Right. In that case, the bicarbonate will be elevated, and the pH might actually be pushed back towards the lower end of the normal range, maybe like 7.35. The bicarbonate has buffered the acid. See?
I see. So the bicarbonate level helps distinguish between acute and compensated chronic states. Are there other tests mentioned?
Yeah, depending on the suspected cause. The sources mention checking serum electrolytes, especially potassium, because of that hyperkalemia link we discussed.
Right, the H plus K plus swap.
A chest x-ray can help identify lung infections or structural issues. A drug screen if an overdose is a possibility. And ECG monitoring is often recommended, particularly if there's underlying heart disease or COPD, to watch for cardiac effects.
Okay, comprehensive workup depending on the context. So we've defined it, looked at causes, symptoms, that critical hypoxic drive piece, and diagnosis. Let's talk treatment. What's the overall strategy according to the sources?
The main goal stated is simple. Improve ventilation. Get the CO2 out more effectively.
Makes sense. Fix the underlying problem.
Exactly. But how you do that depends entirely on why ventilation is inadequate. It's not one size fits all.
So tailored treatment, what specific interventions are mentioned?
Several things. Pharmacologic agents are listed. bronchodilators to open airways if there's spasm,
Okay.
antibiotics for infections, maybe thrombolytics or anticoagulants if it's a pulmonary embolism. Pulmonary physiotherapy like chest PT and nebulizer treatments can help clear out mucus.
Getting the airways clear.
Right. And adequate hydration, they suggest 2 to 3 liters a day helps keep secretions thin and easier to cough up.
Simple but important. And oxygen.
Yes, supplemental oxygen fits in, but with that major caution flag. It's given as needed, but the sources emphasize low concentration, specifically referencing the hypoxic drive issue in chronic patients.
Always keeping that risk in mind.
Yeah.
What about more intensive measures like mechanical ventilation?
Yes, that's mentioned too. Mechanical ventilation might be needed if the patient simply can't maintain adequate ventilation on their own, especially in severe acute cases.
To take over the work of breathing.
Correct. But, and this is another really crucial point highlighted in the material, if you use mechanical ventilation, the power tube needs to be lowered slowly, gradually.
Slowly. Again, that seems a bit counterintuitive. If a problem is too much CO2, why not just vent it off quickly?
It seems logical, but the sources explain why that's dangerous. Rapidly lowering the PaCO2 pulls hydrogen ions out of the blood too quickly.
Okay.
This causes a sudden shift in pH towards alkalosis. The blood becomes too alkaline too fast. And remember those kidneys that might have been holding on to extra bicarbonate in chronic cases? They can't dump that bicarbonate fast enough to compensate for this rapid shift, so you can overshoot, causing a severe alkalosis.
And what's the risk of that sudden alkalosis?
The sources warn it can potentially trigger seizures.
Wow. So correcting the problem too fast is actually dangerous in itself. The body gets used to that acidic state, and yanking it back too quickly causes its own problems.
Exactly. It really underscores the body's physiological inertia, especially after chronic adaptation. You have to respect the state the body is in, even if it's technically abnormal.
That's a powerful insight. It shows how everything's connected: lungs, kidneys, electrolytes, brain chemistry, and how long-term adaptation changes the whole approach.
It really does. It's not just about chasing numbers on an ABG report. It's about understanding the patient's entire physiological context and history.
Absolutely. So we started with a pretty straightforward definition, pH and CO2 numbers. We've unpacked quite a bit. The underlying ventilation failure, the stark differences between acute and chronic presentations, that vital hypoxic drive warning, the diagnostic clues, and the really careful, often gradual approach needed for treatment, even the risk of fixing things too quickly.
Yeah, quite a journey through the complexities. And it leaves you thinking, doesn't it? Given how incredibly the body can adapt to chronic illness, creating these sort of new normal states, how should that influence how we approach treating these complex imbalances? Is just aiming for the textbook normal values always the best or safest way? Or do we need to be more focused on respecting that adaptation and aiming for slow, careful adjustments?
Definitely something to chew on. A lot to consider there about the body's resilience and the subtleties of intervention.